Okay, sir, you can start, I guess. Wait, I'll just switch on the thing.
Next slide, Vishnu. So I am Dr. Karthigan. So I will try to discuss hyponatremia in the next 30 minutes is what I wish to do. I have put up some questions, and in between we can discuss some cases which hyponatremia is quite a regular feature in the emergency. And the disclaimer is that difficult questions will be difficult to answer because this is quite a complicated topic. So this session hopes to increase the inquisitiveness in the participants to go back home and read it. This is only a guide to the topic. This is just a basic. With the disclaimer, we'll just start like when call it as hyponatremia. So I think the answer is well known. The arbitrary cutoff is around when it is lesser than 135 milliequivalents. So again, in approaching any hyponatremia, the second question is the most important question. Is this acute or is this chronic? Because in treating a hyponatremia, the most important things become first whether it is hyponatremia, next is whether it is acute or not. So the acute is 48 hours. So anything lesser than 48 hours, we think we take it as an acute hyponatremia and we try to treat it quite aggressively. And if it is greater than 48 hours, usually the brain starts to form other osmotically active substances, mainly glycine and all these substances, to counteract the osmolar difference that is caused by the hyponatremia. So after 48 hours, if we are aggressively going to correct any hyponatremia, it is not going to be beneficial for the patient. So my first point would be hyponatremia, think when it is lesser than 135 milliequivalents. And the second most important thing will be whether we are dealing with a hyponatremia that is acute, lesser than 48 hours, or it is been there for a long time. Dealing with a hyponatremia would be, is it a severe hyponatremia? Are there symptoms for the hyponatremia? For example, there is a new onset seizures. There is a new onset altered mental sensorium. There is a new onset syncope. There is a new onset seizures. So if patient is having symptoms, severe symptoms of hyponatremia, then again this hyponatremia has to be treated. So seizures, coma, altered mental sensorium, all these can be considered as severe hyponatremia. So lesser than 48 hours, the patient presents with a seizure or new onset altered mental sensorium. An elderly gentleman comes to you for around 78 years. The history is like from yesterday evening, the patient had some 10 episodes of vomiting, and from today morning, he's not talking well. He had very myoclonic jerks. He's in altered sensorium, and you find a sodium of 120. We treat it aggressively. So if it is acute, lesser than 48 hours, and if it is symptomatic. See, non-severe symptoms can be like headache, vomiting, very mild confusion, dizziness. These are all non-severe symptoms. Again, in these conditions, we'll have to be careful in managing, not aggressively treating. But if the patient has seizures, coma, any signs of herniation, if there is any unilateral dilatation of the pupil, it can be even a stroke mimic. The patient can have hemiparesis of a side. So it can also be a stroke mimic. Hypoglycemia, hyponatremia are very important stroke mimics. So any such herniation symptoms, coma, seizures less than 48 hours, sodium lesser than 135, 130, usually severe hyponatremia, the sodium is usually lesser than 100 to 120 to 122. इसके नीचे होते हैं. So lesser than 120. Usually 120 के ऊपर patient, although the value is not very important, if the patient is symptomatic, even at 125, we treat the patient based on the clinical condition. But if it is lesser than 120, lesser than 48 hours, and we suspect it is most probably due to hyponatremia, we treat the patient aggressively. So that answers the first three questions. And the first step in hyponatremia evaluation. So the first step in hyponatremia evaluation would be to send a serum osmolality. So we have tried to determine whether it's acute or not. Very difficult, but we can get the history. If the patient was all right before 48 hours, we can see the old papers. So these are all very important things. And we see the patient is symptomatic, it is acute. Then we have to go for serum osmolarity. For anyone in the emergency who doesn't know, we have serum osmolarity that is available. The machine works usually 90% of the times, but the 10% when it is most needed, also it might work. But we'll have to send it, we'll have to get it confirmed in the side lab. In EM1, they do serum osmolarity. It goes in an yellow vial. In a serum vial, we get the reports within 30 minutes. So sending a serum osmolarity is the first and the most important step in managing any hyponatremia. We can also calculate the serum osmolarity using the formula which I think everyone knows: 2 into sodium plus glucose by 18 plus blood urea nitrogen divided by 2.8. But it's a rough estimate, because what we use in the laboratory is an electrode method, and it measures all the effective osmoles that can be measured in the blood. For example, this formula of 2 into sodium plus blood urea nitrogen divided by 2.8 plus glucose by 18 does not take into account if the patient was on mannitol, or if the patient was any other active, osmotically active. For example, the patient was a TERP patient, a transurethral prostatic resection, and he was put on glycine bladder irrigation, and the patient went on to develop hyponatremia. So these other osmotically active particles will not be picked up by the formula that we use. So doing a serum osmolarity is a fundamental. If there is no serum osmolarity, then probably our hyponatremia evaluation gets stopped then and there itself. So sending a serum osmolarity is the first and the most important. The serum osmolarity, as I think everyone knows, the value is somewhere around 275 to 280 is the normal value. If the patient is having, I think everyone knows this, if the patient is having hyponatremia and the serum osmolarity is high, then it can be usually hyponatremia. I think again mannitol. And if the patient, everyone knows this, it's a very important MCQ. I think NEET PG may push if the patient is having hyperglycemia. So for every 100 milligrammes, there are many rough formulas, like for every 100 increase mg per deciliter increase in glucose, the sodium increases, the sodium decreases by 1.4 milliequivalent. If the serum osmolality is greater than 290 and the patient is having hyponatremia, so serum osmolality is the first investigation. If it is lesser than 275, then it goes into the track that it is a hyponatremia, that is a hypotonic hyponatremia. If the serum osmolarity is high, greater than 280 or greater than 290, then we are dealing with some kind of a pseudo hyponatremia, where there are other osmot. Because I still remember a case where we got a patient from RPC. The patient had presented with altered mental sensorium with new onset renal failure. The patient was, we were evaluating, the patient's sodium was somewhere around 125. मैं सोचा था sodium ऐसे आएगा 125. It is whether it was significant or not, we didn't know. We were evaluating, we started treatment, there were query neck signs. The patient had actually cervical spondylosis. We thought it is meningitis. We started vancomycin, we sent blood cultures, we sent the patient for CT. CT came out to be normal, antibiotics chal raha tha. The patient started to develop severe metabolic acidosis, and it was a high anionic metabolic acidosis. Lactates were normal, glucose was normal. Then we didn't know what to do. What is the cause for a high metabolic, high anionic metabolic acidosis, and the patient is altered mental sensorium? So as we all know, in any high anionic metabolic acidosis, next we did a serum osmolarity. Serum osmolarity came to be 330. And the calculated osmolarity was only 280 or something. There was an osmolar gap of almost 40. So this patient had a high osmolar gap. The patient had a hyponatremia of around 125. Then I remember Shrisha sir, who was then the 5th semester JR, in the night, he got all the old papers, and it was shown that the patient was being treated for acute glaucoma in RPC and was on mannitol for almost 7 days. He was on mannitol and he was shifted because of altered mental sensorium here, and mannitol was a substance that increased the osmolarity. So it was a pseudo hyponatremia. The patient was in hyponatremia and it was mannitol toxicity. I think we lost follow-up of the patient, but the patient got intubated because it took almost more than 36 hours for us to make a diagnosis that it was hyponatremia that was causing all the symptoms for the patient, and we were managing it like meningitis. So again, serum osmolality, we always need to be very careful with serum osmolality here. So it's a very important list. So in our patient, this imaginary patient, I think I've taken 7 minutes. We have covered 4 questions. We'll make it quick. So lesser than 135 sodium, a patient came. He has the symptoms. I'm only going to talk about acute. Chronic is quite difficult to be covered. So lesser than 48 hours, the patient has symptoms like new onset coma, seizures, altered sensorium, herniation signs, and we went on to do a serum osmolality. The serum osmolality, if it is high, there is hyponatremia. We think about other factors, osmotically active, and the serum osmolality is low. That is, if it is lesser than 275, and the patient is having hyponatremia. Then next thing is to look at the volume status. So look for serum osmolality, look for if there is hyponatremia or not hyponatremia with a low serum osmolality. Next is to check for the volume status, whether the patient is euvolemic, hypervolemic, or hypovolemic. Again, checking volume status is anyone's game. People can use the IVC, people can look at the capillary refill time, ask them to stick out their tongues, look at their eyes, whether there is dehydration, anything. So we'll have to assess if the patient is euvolemic, hypovolemic, or hypervolemic. So we have come the 3 steps: serum osmolality, whether there is hyponatremia or not. Then we went on to see the volume status. So it's, I think, these 3 important things we would have got. Next is to do a urine osmolality and a urine sodium. Again, these 2 investigations are done in our emergency. Urine osmolality is done in the side lab. You just need to send some urine in a vial in a yellow form, right? Urine osmolality, 30 minutes ke baad report milega. Urine sodium, it is done in smart lab. The only unsmart thing about the smart lab is the person, there is no one to take this urine sodium from the emergency up to the smart lab. So the reports are delayed by just 48 hours. But again, it is done. And if we are really interested and if we push, we might get it done quickly. So urine osmolality is a side lab procedure. We can get it within 30 minutes. But urine sodium, time lagte hain because it has to reach the smart lab, which is which is quite far away from the emergency. So urine osmolality, urine sodium, dono hum idhar karte hain. So when the serum osmolality is low, for example, lesser than 275, it is 270, it is 260, whatever, and the urine osmolality is high. So the cutoff, there are multiple cutoffs. Some people take it as 100, some people take it as 300, but let us go with 100. So the urine osmolality is high. That is, the urine is getting concentrated, but the serum is not sufficiently concentrated. That means then, and the patient, so we have, let us say, take this patient. The patient had hyponatremia. The patient had hypotonicity. That is, the serum osmolality was low. It is 260. Patient is having hyponatremia. And the urine osmolality is greater than 100 and the patient is euvolemic. That is, the patient's volume status is preserved. Then we are probably dealing with the most fearful complications of hyponatremia, causes like syndrome of inappropriate ADH secretion, or it can be psychogenic water consumption, like in some psychiatric cases where the patients go on to drink a lot of water. So the most important 3 things here is hyponatremia was there. The patient had an acute symptoms. We did a serum osmolality. The serum osmolality was low. Then I went on to check the volume status. The volume status of the patient was euvolemic. Then I went on to do a urine osmolality. The urine osmolality was greater than 100. Then I am dealing with a euvolemic hypotonic hyponatremia, the classical picture that we usually call as syndrome of inappropriate ADH secretion. There are little more factors to be added in it. So that is the, if the patient was hypovolemic, see, hypovolemia aate hain, so it is very, very simple. Next, we will have to ask, sir, ulti aaya tha, or the patient had diarrheal episodes. So it becomes very simple. If you find the patient is dehydrated and the patient is having hypovolemic hyponatremia with hypotonicity, it is just fluids. You give RL, the patient will start to improve. So it's very simple. Hyponatremia, the volume status of the hyponatremia, serum osmolality is low. Whether even if you do or not the serum osmolality, it's a different ball game. But hyponatremia, the patient is dehydrated fluids. Just forget about it. There is some kind of an exogenous fluid loss. The patient is volume overload. That is heart failure, liver cirrhosis, nephrotic syndrome, hyponatremia, volume overload. You will only have to diurese the patient. That is a different ballgame. So volume status becomes the most important thing apart from serum osmolality here. If the patient is euvolemic with a low serum osmolality, then urine osmolality and urine sodium comes to play. So please check the volume status, which is a completely clinical examination. So I think I have made myself clear about the volume status and urine osmolality, urine sodium. So urine sodium values is usually we take a cutoff of greater than 40 in the SIAD case, where urine osmolality greater than 100 and urine sodium greater than 40 with a serum osmolality lesser than 275 with hyponatremia comes under the euvolemic hypotonic hyponatremia. If the volume is low, it is dehydration, fluids there though. If the volume is high, heart failure, liver cirrhosis, nephrotic syndrome, renal, heart, liver. It is only diuresis. We need not treat it. So with this, we come to what are the causes or factors that cause ADH. We know ADH becomes antidiuretic hormone is the fundamental here. So ADH is secreted in the posterior pituitary, I think somewhere near the supraoptic nucleus. For people who appear for the exams, it might be a question possibly. And anything like pain, fear, anxiety, these cause ADH secretion. And the other thing that causes ADH secretion is increasing serum osmolality. If the serum osmolality is increasing, for example, when there's excessive volume loss in the body, the osmolality will increase. So this will reach the posterior pituitary and it will secrete ADH, antidiuresis, to conserve water in the body. So decrease intravascular volume, increasing osmolality, pain, fever, panic reactions, all these are the causes of increased ADH secretion. ADH acts somewhere in the collecting tubules. It forms, I think, aquaporins through which fluid is retained in the body. So this is how ADH acts. So that is about ADH secretion. And about coming to syndrome of inappropriate ADH secretion, it's a very, very important thing. This entire topic rests on this fearful condition. Patient has severe hyponatremia. The serum osmolarity is low, lesser than 275. The patient's urine osmolarity is greater than 100. The meaning why urine osmolality greater than 100 is important. Actually, urine osmolality will be usually greater than the serum osmolality. That is greater than 300. Actually, that will be. It means that the serum osmolality is 264, but the urine osmolality is 300. That look at the gap. The serum is low. It is only 264, but the urine is having a higher osmolality. So that is syndrome of inappropriate ADH secretion. More than what the physiological cause should cause an ADH secretion, the secretion of ADH is more. That is it. So it is hyponatremia in a euvolemic patient with a high urine sodium and a high urine osmolality. So that is SIADH. So causes of SIADH can be anything under the sun. But always remember, I still remember a case. He was a 50-year-old male. He is a known case of CML. The patient presented with altered mental sensorium, and it was like stroke. It was hemiparesis on one side. It was within the first 1 hour, and we immediately thought it is stroke. Immediately called the neuro-SR. There was an IV line put and neuro-SR or CT19 along with contrast, and before sending, by chance, someone sent the VBG. Some good JR was working there. Somehow the VBG also came. Grateful that day the EM1 VBG machine was perfectly working. It went in and the report came out and the sodium was 108. And it was like 1 hour stroke. It was the patient just had one thing, pupils were equal, he had hemiparesis of one side. Now we were like confused, but we thought, TK, we will correct it. We gave one bolus dose of 3% NaCl and we gave a second dose of 3% NaCl and there was no improvement. We gave the third bolus of 3% NaCl and the patient actually had mild improvement in symptoms. He was like V4 status meta. He was able to now vocalize, but yet we went on to do an NCCT. The patient had an SDH. So it was an SDH that was compressing, and that led to a syndrome of and by that time we had sent the serum osmolality and urine osmolality. Serum osmolality was around 250 or something. The urine osmolality was around 330. So, and the patient had hyponatremia, no renal failure, no liver disease, no heart failure, and the bunuria, the bunuria nitrogen was dilute. The uric acid was around 4.2. These are all some of the other cutoffs that we need to think before diagnosing syndrome of inappropriate ADH secretion. I think it also has a name, this criteria. So again, the important point is any CNS lesion, think about hyponatremia. Any elderly male presenting with altered mental sensorium, before we make a bada diagnosis, think hyponatremia. It's as simple and straightforward like hypoglycemia, but what the mind does not know, the eyes will never see. So it's very important that we think about it. So yeah, I will finish within the next 10 to 12 minutes. So, so what are the causes of CR? Anything under the brain, meningitis, encephalitis, SDH, and any kind of any lung infections, tuberculosis. I think that small cell carcinoma, the most importantly currently asked neat question: what is the paraneoplastic syndrome that is caused by small cell carcinoma? Again, CR comes as the best answer. And even positive pressure ventilation can cause this. So anything under the sun, and all these neuropsychiatric drugs, carbon, I think the D2 blocking drugs, all these SSRIs, all these drugs have a high propensity to cause CR-like manifestation. So taking an important drug history is very, very important, because all these kind of drugs, CNS lesions can cause. And the most feared thing in managing a hyponatremia is osmotic demyelination syndrome. People will be really worried. Even if you go on, if anyone has treated in the counter, if you go and say to the staff nurse, um, सिस्टर जी वो 3% saline है ना, वो 100 ml bolus, she'll be like, bolus sir, आप sure हैं क्या? Bolus. Somehow the fear of 3% saline has penetrated and caught everyone's head. They believe that एक bolus 3% saline, that's odious आएगा and the patient will die. That is a fear that we need to. The truth is, the chances that we will die because of improper and inadequate treatment of hyponatremia is 10 times greater than the fear that after because for ODS to develop, it minimum takes 1 to 2 days, and you should have been correcting overzealously. Like, well, come on, let's correct it to the person. I am like a perfectionist. I will read 100 per 100. I will correct up to 135 milliequivalents. So overcorrection only causes ODS. Otherwise, single dose of 3% saline in an acute condition, kuch nahi hote hain. And the fear that we will cause ODS is much worse than, I think it is like very, very minimal probability. How many ODS we would have seen? It would have been like very, very few. So again, ODS ka risk factors, what many textbooks say is hypokalemia, malnourishment, alcoholism, and cirrhosis. So this hypokalemia is a very interesting thing. I think there is some kind of a formula. I think anyone interested can go and read. I also forgot. But in a hyponatremia, many times correcting the hypokalemia, the concomitant hypokalemia, actually improves the hyponatremia. There is actually a formula, there is actually a concept behind it, which I could not read. But correcting hypokalemia helps in correcting hyponatremia in a much faster and a better way. There is a physiological factor behind it. So the risk factors for osmotic demyelination will be a malnourished, alcoholic, cirrhotic, a patient with concomitant hypokalemia. So these 4 factors, again, we will have to think. So CR, when to suspect again. So this is a textbook question. Low serum hyponatremia with low serum osmolality lesser than 270, and the patient is euvolemic, and the serum osmolality is greater than 100, urine osmolality is greater than 100, and the urine sodium greater than 40, and the patient has no thyroid, adrenal issues, and his kidneys, heart, liver, and renal functions are completely normal. इतना चीज होते हैं तो then we can diagnose CR. Probably no one will have CR. Someone will have some box ticked. छोड़ दो. The patient is symptomatic. Then we will treat it as a symptomatic hyponatremia. So that's an interesting question. 11th question: what common drug leads to CR in elderly? Well, this I this is not an MCQ, but I worked in nephrology as a junior resident, non-academic junior resident, and my professor always used to say thiazide diuretic. This thiazide is notorious to cause SIADH in the elderly. It will not cause immediately. The patient will be started on a thiazide diuretic. Please go and read about it. I think 1 month back. But this thiazide, what it causes, it would cause a small reduction in the circulatory volume of the patient, and that would increase the osmolality, leading to an increased ADH secretion, leading to a new onset CR-like presentation 1 to 2 months after a long time after onset, especially in the elderly. Loop diuretics don't cause, but if an elderly male suddenly presents with hyponatremia, please ask about thiazide diuretic, which is a very noted point. Many people talk about this thiazide. What is the reset osmostat? So, Vishnu, can we go to the next slide? So, reset osmostat again is just a theoretical concept. You see, in many pregnant people, in pregnancy, then see, hamara osmolar status is 275 to 280 is our normal osmolarity. In pregnancy, because of there is circulatory relative volume increase, this osmostat is actually reduced. So there is increased ADH secretion at even at 260 to 265. So the patient will always have a mild hyponatremia with he will not have any symptoms, but the osmolality will be on the lower side, and patient will have mild hyponatremia, which is very because the physiologically ADH gets secreted at a lower osmolarity in pregnant women, which is called reset osmostat, which is a physiological thing. No need to aggressively treat a pregnant. So no need to aggressively treat any patient who is asymptomatic. That too in a pregnant woman, we need to think about all these physiological things. So that is called reset osmostat. So next will be what is exercise-induced hyponatremia. Again, very interesting. I think emergency medicine. One day we might have a marathon. Delhi marathon will happen. Someone will collapse and will come to us, and we do the sodium might be hyponatremic, and the patient will be like, sir, I am a fit male, I am running a 21 kilometer marathon, how can I get hyponatremia? So again, we already discussed pain, panic are all causes of ADH secretion. And if he's an amateur runner like me, I would not take good fluids for running. I would take water and go. Already ADH will be secreted, and I will be drinking water when I am running. So the patient will go for a new onset SIADH like presentation, because pain, panic, fear will already cause ADH secretion, and I will be taking more hypotonic solutions. The patient will go for exercise-induced hyponatremia, can present as seizures. That is why I think even when marathon runners, everyone, it is said, it is not said, they are given electrolyte containing fluids while running. No one takes water while running. Electrolyte containing fluids. So that is exercise-induced
थोड़ा
hyponatremia.
स्नैक्स कुछ है क्या, बिस्किट बिस्किट टाइप का?
And okay, I think that was not a question. Anyway, 13 was, I had a hyponatremia patient. I gave normal saline. It worsened. What do I think? So very nice question. Self-appreciation. The patient if had a sodium of 100 125, and you thought the patient is hypovolemic, and you gave the normal saline 1 liter bolus in the counter, and the patient had worsening of symptoms. What does it mean? The patient is not having a hypovolemic hyponatremia. He's having a euvolemic hyponatremia like CR presentation. So the patient is already having a low osmolality, serum osmolality of around 260. And you are giving more hypotonic solution, because normal it is like 154 millicoulomb per liter. That is the maximum osmolarity of a normal saline. So you are much more diluting. You have 254. That is low serum osmolarity, and you give 154 as the fluid. Matlab, it will cause more dilution. It will cause worsening. It is not the right way, but again, this is a trial and error method in a patient that is little confusing. People usually give a trial of RL or NS, and if it worsens, the symptom worsens, then it is 100% not hypovolemic hyponatremia. It is usually euvolemic hyponatremia. So if you don't have any serum osmolarity you don't have any urine osmolality, and you are working in this is like the typical anything we do when we put a central line. People are like, why do you use an ultrasound? Tomorrow you might work in a periphery where there is nothing. So you work in a periphery where there is nothing. You find hyponatremia, and you don't know what to do. You give normal saline. Patient worsens 100%. You are not dealing with a hypovolemic hyponatremia. You are working with some kind of a euvolemic hyponatremia. That is why the patient worsens. So that is it. So then,
Karthikeyan, just a minute there. Sorry to interrupt.
sir,
Just one
sir.
point I'd add over there is what you described right now is basically your isotonic fluid challenge test, basically, where you give sodium chloride and it sees. So the thing over there is it is not advised, like unless, like you said, it's in a remote setup where you don't have any other diagnostic means. It is not advised, basically. So, like you rightly described, basically, after giving this, you look at the serum sodium and the serum sodium as well as urine sodium. So, if the serum sodium worsens, like you have already said, then it is equivalent to basically having a dilute urine, like in your SIDH or setup. If it's not, if the serum sodium is actually increasing, then that rules out a cause like an SIDH or a euvolemic hyponatremia, and you can then focus on rehydrating the patient or treating the acute cause that is there. So I just wanted to add that that is what the isotonic fluid challenge test is. Okay, continue.
Thank you, sir, Arvind, sir. So and so we have how much to correct, and I corrected 4 milliculons. Yet the symptoms persist. What to do? So in the counter, you find a patient who is having active symptoms. Seizure, altered sensorium. The sodium was around 118. You give 3% saline, 100 ml IV bolus. And there are a lot of formulas we know. The recent practices states that in treating an acute hyponatremia, acute lesser than 48 hours, severe acute hyponatremia with symptoms, give a bolus dose, wait for 5 minutes. Within 5 to 10 minutes, you can repeat a sodium. If there is no improvement in the symptoms, you can give another bolus dose. And if you can give up to a maximum of 3 boluses. Usually, by 2 boluses, the sodium will improve by 4 milliequivalents. And most symptoms usually resolve when the sodium is corrected by 4 milliequivalents. So first bolus you give, you repeat a sodium, or if the patient has no clinical improvement, you give a second bolus. Usually by 2 boluses, there will be at least 2 to 3 or 3 to 4 milliequivalents rise in sodium. A 4 milliequivalent rise in sodium usually corrects the acute symptomatology of the patient, and that is more than enough, and that is more than required. By the time, the best way to assess whether sodium is improving or not is repeat BBGs. Every 15 minutes is said to be in acute hyponatremia management. Every 15 minutes is a very good way of assessing whether we are treating on the right path. And for that question, I corrected 4 milliequivalents, and yet the symptoms persist. What do I do? There is something adding on
I see.
altered sensorium or so there is something that is
यार ये क्या होता है यार?
so there is something that there's also another cofactor that is causing the symptoms in this patient. So anything that does not get corrected, if the symptoms don't corrected when the sodium is corrected by 4 milliequivalents, you have corrected, you gave 2 boluses, yet the patient is having symptoms, that is something else. For example, in that patient whom I told, we had corrected the sodium by 4 milliequivalents, and yet the patient was having residual weakness. We did a CT, there was an STH. So remembering that case, if the symptoms are not corrected by 4 milliequivalents, because the maximum correction that we need to do in a day would be 4 to 6 milliequivalents in an acute hyponatremia. Anything greater than 8, we are at risk for ODS. So we only need to correct 4 to 6, forget all the formulas. We can go for boluses. And that is the recent recommendations. If the patient is having an acute symptomatic hyponatremia and you think the patient is a euvolemic acute symptomatic hyponatremia, this is the way to manage the patient. And the other questions would be persisting SIADH. Many times the problem what I think we would have corrected 4 milliequivalents. The patient would have thoda improvement bhi ho gaya, and we would shift the patient to yellow. And once yellow jaane ke baad, someone would start RL, and the patient will go for another worsening of symptoms. See, if the patient is having a small cell cancer of the lung, the patient is having CR. Do you think the CR is going to get corrected with just 2 boluses? No. The primary is the syndrome of inappropriate, is the small cell malignancy. The patient will have continuous syndrome of inappropriate dehydration. So, in any patient you are suspecting syndrome of inappropriate ADH secretion, you need to think about volume restriction. You can't be giving hypotonic solutions. You need to be giving extra salt. Even extra salt is not recommended. You need to curtail dilute fluids. You must write it. Please avoid unnecessary fluid administration. You must avoid fluids that have an osmolarity lesser than your serum osmolarity. See, if your serum osmolarity is 250 and you give something of around 150, it costs more dilution, it costs more SADH, it causes more cerebral edema features. So it's very important that you follow up the patient. That is why managing a patient of acute hyponatremia that is treated in the emergency becomes difficult. Many people see many handovers take place, but it's very important that you note that if the patient is having a CR, you have corrected it. You see to it that the patient does not give unnecessary diluent fluids. You go for water restriction, and you are very much trying to find out the cause why the patient had a CR, whether there's a malignancy, whether there's any CNS lesion, whether there's tuberculosis. That is very, very important. You correct the acute hyponatremia, but you always think it can again recur as long as the primary problem is not corrected. So persisting CR, what to do? That will be with fluid restriction and avoiding diluent fluids. What is the when to think of desmopressin? So desmopressin, this is like just take 3 or 4 minutes. See, we corrected syndrome of inappropriate dehydration. There is 4 milliequivalent increase in the sodium levels. We put a Foley's catheter. And if the urine output is like greater than 100 ml per hour, and if the urine sodium is persisting to be greater than 100, so they call it the 100-100 rule. If the urine output is greater than 100 ml per hour, and if the urine sodium is persistingly to be greater than 100 milliequivalents, then there is high risk that the patient will go for overcorrection. So there is excessive urine that is coming out. So the sodium is going to get it is going to get corrected on a very fast rate. So we always need to put a Foley's in correcting a patient with hyponatremia, because without monitoring whether urine output is there or not, how much is it, it will be very difficult. So point is Foley's catheter डालना पड़ेगा. And this desmopressin, so whenever we think the correction is greater than 5 or 6, then desmopressin has a role. We don't have IV desmopressin available, at least in any of the pharmacies around the AIIMS. We have written it many times. We get only a nasal spray. The nasal spray, no one knows the efficacy of the nasal spray. It is like for every 0.1 ml, there is 10 micrograms, but the dose of which to control this, we don't know. So again, that is a point to ponder for people to give us a feedback on desmopressin in managing in an emergency names. We don't have it available. So the best thing will be judicious volume restriction, avoiding diluent fluids, and if the sodium is getting corrected at a very fast rate, then we will have to think about starting hypotonic solutions to keep the sodium lesser than 8 milliequivalents correction in the first 24 hours and not greater than 12 milliequivalents in the 48 hours. So that is very, very important. So you correct it, you छोड़ने के बाद हम नहीं जा सकते. We'll have to think about what is going to happen for the patient in the next 48 hours. So is it available? We don't have it available. So last 3 things. Vaptans, oral urea. I think oral urea is an MCQ. People can go and read. It's a new concept that is coming up. It's a very interesting thing. Vaptans. So Vaptans, these are the V2 blockers, the aquaporin blockers. Hyponatremia, kuch role nahi hai because it is very unpredictable. It comes in 30 mg. Tolvaptan comes in 30 mg. And it is available. We can give, but no role in correcting acute hyponatremia. The only role for Vaptan is in a patient with heart failure with reduced ejection fraction. Hyponatremia is a harbinger of poor prognosis. In any patient with any hyponatremia in CLD or in patients with heart failure, hyponatremia is a poor prognostic marker. We can't give in liver failure because Vaptan can cause liver failure. So we can give about a maximum of 30 days. Vaptans can be used in chronic heart failure with hyponatremia. So that is the only role for Vaptans here. And so my take home points would be: you find hyponatremia, you try to ascertain whether it is acute lesser than 48 hours. You see if there is symptoms, acute hyponatremia. You treat with 3% saline. As brave as you can, at least one bolus directly you can give. The next bolus you can ask the academic SR, you can ask the SR over there, ma'am, can we give, sir, can we, and you can give 2 bolus. Nothing is going to happen. And you correct it to a maximum 4 milliequivalents. If it is not getting corrected with that, then there is something underlying CNS or some other lesion that we have to evaluate. We can send serum osmolality, it is available with us, urine osmolality is available with us, and urine sodium can be sent to smart lab. The patient is hypovolemic, give fluids. If the patient is hypervolemic, we'll have to diurese with furosemide. Euvolemic is all the problem that is CR. I think we have discussed it. The last thing is cerebral salt wasting syndrome. Vishnu, I think I'm only giving you 15 minutes. I'm very sorry, but just 30 seconds.
No, sir, no issues.
Cerebral salt wasting, I haven't seen. I have just heard it is a neurosurgeon's nightmare. The same SAH or SDH can initially cause CR in the first 1 to 2 days, because once a neurosurgical insult happens, the first 2 days there is inappropriately high secretion of ADH, and after 48 to 72 hours, this ADH just becomes zero, because there is so much injury, there is so much cerebral edema, that there is no more secretion of any ADH from the brain. There is loss of cerebral tone. And what started as a syndrome of inappropriate dehydration, after 48 to 72 hours, the patient can just go into cerebral salt wasting syndrome. The exact pathophysiology is not known. I have not seen a case, but I have heard when I was working as a non-acad JR. So non-acad JRship is an incredible learning experience. I have heard from neurosurgeons saying, if the patient starts to become, so the volume status, we always think that volume status ये क्या होता है, directly हम IVC देख सकते नहीं है. It is seeing the pupil, it is seeing the eyes, sunken eyes, it is seeing the capillary refill time. इसमें होते हैं. The patient becomes dehydrated and hyponatremia. In a patient with any CNS lesion, the patient can slip from an SAADH into a cerebral salt wasting syndrome. There is no way to differentiate except in seeing that the patient is having dehydration. In cerebral salt wasting syndrome, there is no restriction. See, in CR, there was restriction. You give 3% saline, 2 bar, you correct it 4 milliequivalents, then you maintain it. You don't give diluent fluids, you don't worsen it. But in cerebral salt wasting syndrome, you give fluids, you give extra salt, you give 3% saline, you also give fludrocortisone that is available in 100 micrograms. Fludrocortisone is a very interesting drug. It is like an aldosterone agonist. It is available in the market. People use it for postural hypertension. My grandfather was using it for postural hypertension. It is like an aldosterone agonist. So we always need to think in an SAH patient, SDH patient. The patient who is an CR patient can deteriorate into cerebral salt wasting, and nothing can differentiate between both of them except the patient will become dehydrated. So volume status becomes very important. And any questions, I would refer and get back to you. But I think I'm thankful for Mehul sir for persistently having these sessions. And it's over to Vishnu for hypokalemia.
Sir, I just had 1 to 2 doubts, and after clearing that, if we have time, we'll just move forward to hypokalemia, whatever I have prepared. So even if you mean by bolus, is it like you're just giving it over 1 to 2 minutes, or does this say giving it over 10 to 20 minutes? Does it have something to do? Because usually when we write it, all the nursing staff gives it over 10 to 20 minutes. Should that actually be followed, or should it just be given as a bolus over 1 minute? What is your take on that particular thing?
Well, see, there is no actual guidelines in stating that it should be given over 10 to 20 minutes or over time, but it is just a bolus though. So 3 to 5 minutes, it is like giving dextrose. You can give it as a bolus. There are no indications. See, I have based my presentation on, there is an MCRIT hyponatremia. It's an incredible article. which is available, free article available, and also based on current medical diagnostics and treatment 2022, and also so there is no timeline given in any of these three things. Even when I correct, I tell give it over 5 to 10 minutes because I am also little afraid. But if anyone can throw more light, I will be very. But there is no timeline stated that this has to be given 1 to 2 minutes or 5 to 10 minutes. It's not there.
And
Karthikeyan.
Sir.
Very wonderful presentation. I think you mentioned all the important points. So, just want to add on that thing. There are two guidelines for hyponatremia in the ED. One is the American guidelines, and one is the European guidelines. The European guidelines are much better than the American guidelines. Even the Americans admit that the European guidelines are much better. They basically brought everyone in Europe who are knowledgeable about hyponatremia, and they made a guideline on it. And what they say is to give a bolus of 150 ml of 3% NS over 20 minutes. So it's not over 1 or 2 minutes, it's over 20 minutes actually. So we are not actually doing anything wrong by giving it slowly. But we give it 100 ml, they have written 150 ml, we give it about 100 ml. And they were advised is to repeat serum sodium after 20 minutes. After the infusion, we wait 20 minutes and we repeat infusion, repeat the serum sodium again, and we see if there is improvement. And we keep more, and this is only for acute symptoms. Acute symptoms are usually seizures or acute alternate mental status, and we keep bolusing until the serum sodium increase by around 5. After we are increase by around 5, we don't give any more bolus. We just give maintenance IV fluids after that, and that is one thing. That is what the European guidelines say. And I think that is the most useful thing for us in the ED, and it's very simple to understand because there's all of the other. The rest of the thing that you said is very important, but it's a very complicated flow chart and might be difficult for some people to understand. But the guidelines are very simple. If you think it's acute and think it's having severe symptoms, usually seizures or acute altered mental status, you can give bolus. You increase by around 5 and it maintain it around 5. Give maintenance fluids and don't go more than 8 over 24 hours. And the second point that I'd like to make is that the risk for ODS, it is over 24 hours. So even if you overshoot after 2 hours, you can still make sure that the patient doesn't have ODS by making sure that they doesn't go too much over it by giving desmopressin. So that is another concept where we give desmopressin in case we overcorrect the sodium. We can use desmopressin to cancel that out. So that is one. That is another thing
we don't have desmopressin help with us, sir. I think many times we have tried written it outside. We have never got desmopressin. The IV form, that is, I think the dose is some 2 micrograms IV every 8 hourly. We can have a desmopressin lock. Itna bolte hain, but the problem is we don't have the IV form that is available. Only the nasal form that is available. We don't know what is the conversion of the nasal to the IV, whether some people have written some it's like 10 micrograms per kg body weight. So that would be whether that is for hyponatremia management, because only IV has been written for overshooting. So that is an issue for us.
I completely agree. We have no idea about whether or not the intranasal is effective to begin with when we're using it for this particular purpose. But if we have nothing else available, we have to try something. So if we have no other options, we have overshot this for some reason, then we have to consider this. But another thing is, most of these problems happen during shift change. One shift will see the patient, will assess the patient, they will decide what is needed for the patient. Then the shift change will happen, and then the new shift will come and they may or may not get it proper over. And then that is where things get wrong. And often what will happen is that they will overcorrect. So they will. So that is a big practical problem that will face. Once you are corrected up to 5 milligrams, that's what the guidelines say. You increase up to 5, then you start maintenance fluids. What happens often is that when you next shift comes, they will again give the bolus, and then the patient will overcorrect. So that is often when the patient becomes at a high risk for ODS. And Another thing is the patients are at high risk for ODS are going to be the patients who have chronic malnutrition, chronic alcoholics. They are generally at higher risk for ODS.
And just another one doubt that I had is while you were talking about managing the thing that Arvind sir said, the isotonic fluid challenge test. So what was it exactly? Like the patient is in CR and you're giving isotonic fluids, it is going to worsen the patient. Was that what the whole point was?
Exactly. So
and the reason behind it being?
The very simple concept, your serum osmolality is 264. Okay. And you're having symptomatic for a 264 serum osmolality, and your sodium is around 125 or something. I am going to give a fluid like NS or RL, which is an osmolality of around 154 in 1 liter. Am I right? That is the osmolality.
I think 286, no, sir. It is like 154 of. It contains 153 of sodium and it contains 153 of chloride as well.
Osmolality
is going to be more than, I think it's somewhere around 285.
308. NS osmolality is 308.
300. So that is one point that I did not understand.
So, Karthikeyan, you want to take that or?
Sir, would you take that, sir?
Okay. Okay, so basically, no, the point is it's called an isotonic fluid challenge. So when you happen to give an NS over there, it's not about the osmolarity basically that is being affected over there. What you're happening is the pathophysiology you're looking at is basically inappropriate ADH, right? So when you are giving more fluid, about 1 liter of fluid, you're giving what should you do in SIDH? Basically, it's fluid restriction. You are giving more fluid to this patient. So whenever ADH secretion is inappropriately increased, no matter what the fluid you are giving, the antidiuretic hormone action is going to be predominantly established and the fluid retention is going to be there along with the sodium excretion from it. You understand, right? So that is why giving extra fluid in that case is only going to worsen. And while there is sodium loss along with fluid retention, it will worsen the hyponatremia that is present while maintaining euvolemia. Do you understand my point, Mr. Kutan?
Now I understand the point.
Yeah, so basically, if it is a euvolemic hyponatremia, there are basically two important. One is this thing, and one is your SIDH, and one is otherwise if you're having, say some like psychogenic polydipsia or like something like that. So, if you're looking at if it's an ADH dependent mechanism and you give more fluids, when there is inappropriate ADH secretion, obviously the water retention is going to be there along with sodium excretion. So that is going to worsen your hyponatremia. Whereas if it is not an ADH dependent mechanism, it's not a euvolemic ADH dependent mechanism, then what happens is when you give the fluid, that will actually help in counteracting the hypovolemia. So that will actually result in, and you're supplementing sodium also at 154 along with fluid waters. So if the ADH acts correctly at that point of time, or the renal tubular concentrating capacity is okay, then that is actually going to improve the patient or improve the sodium levels. So that is why it is known as an isotonic fluid challenge. Is the concept clear?
Yes, sir. I understand your explanation, but the doubt I am adding one more doubt on top of this. Like, okay, this is when you're talking when a euvolemic hyponatremia patient is given a fluid challenge test. And his hyponatremia actually worsened.
Okay.
Right. That is what you're looking at, right?
Yes.
Yes. So my question is, like, from whatever I understood, even when the patient is in a hypovolemic hyponatremia, that is also a strongly ADH related condition.
Not always. Not always.
So my question is, once you give that bolus of fluid, the ADH gets suppressed because it no longer, I mean, since we are correcting the hypovolemia per se, the ADH need not be secreted.
No, that is not the dominant mechanism.
So my question is, the ADH is not getting secreted in that much of an amount. It will result in a more dilute urine, and the patient can go in for an overcorrection of sodium also, right? I mean, at least that is what I understood after hearing Encrit. If I'm not wrong. Okay. Okay. No, your point is, see, basically it is a dynamic thing. It is not like your ADH secretion is maintained at a constant level depending on your pre-correction sodium. It keeps on changing and fluctuating basically. So your ultimate point is to maintain your serum osmolality and your serum sodium back to normal levels. That is how your ADH functions. So depending on that, your ADH levels keep fluctuating, which is why SAADH is notorious in the sense that it is inappropriate ADH secretion. Yeah, nahi hai to even if it is not ADH dependent, your other mechanism is basically your renal tubular concentrating capacity, right? So to answer your question, basically, if you give a fluid, the ADH secretion modulates itself accordingly if the patient's pathology is ADH independent. Suppose it is extrarenal losses, like you're saying कि profuse sweating हो रहा है patient को, या नहीं है तो gastroenteritis हो रहा है and the patient is coming with hyponatremia with associated hypokalemia and all that. So basically in that case your ADH as well as your renal tubular capacity are completely fine. You replenish the sodium chloride and the fluid balance of the patient, your ADH secretion is going to be just fine enough to maintain the water and the sodium balance. In which case, your serum sodium is going to improve as well as your serum osmolality is going to come down. You understand my point?
Yeah, I understand it.
So it's basically if your ADH function is normal and if your renal tubular capacity is normal, then the body is going to respond to the isotonic fluid challenge in a positive way. Is that clear, Vishnu?
Yeah, it's clear. It's clear.
And also that about that dilution with NSS, I think if we also depend on the urine osmolality. If the urine osmolality of the patient is somewhere greater than 350 or 400, and we do a serum fluid that has osmolality of around 300, so it is again going to cause more volume dilution because the urine osmolality is very high. It is around 450, and we give a serum fluid that is 300 milliosmoles, then it is again going to cause increased volume dilution. Again, that is also another issue in the fluid balance sector.
If anyone else has any doubts that they would like to ask at this point.
I would like to just give a summary of the evaluation of hyponatremia, just very, very briefly. So first of all, we basically only have three tests we need to do for hyponatremia. One is serum osm, then we have do urine osm, and then we do urine sodium. So we just do basically the entire evaluation depends on three tests only. And first we do serum osm because we want to know whether the hyponatremia is real or not. Because sometimes it can be artificially low in some conditions like hyperproteinemia, hypertriglyceridemia. These conditions can cause artificially low serum sodium levels. Or due to certain medications like Karthikeyan said, mannitol and such medication can cause low sodium levels. That is also possible. So in true hyponatremia, the serum osm should be low. So that is the first test we do. So that is just to confirm that the thing is real. We really do have hyponatremia. The second test we do is for urine osm. Why do we do urine osm? To decide whether it is an ADH dependent process or whether it is an ADH independent process. If it is an ADH dependent process, then we divide it into hypovolemic, euvolemic, and hypervolemic. If it is an ADH independent process, that means the urine osm is low. So what is the basic function of ADH? ADH will concentrate the urine. So if the urine is concentrated, what would happen? The urine osm will rise, usually more than 200 to 300. So it will rise. So that is a basic simple way of thinking about it. So if the urine osm is low, that means it's an ADH independent process. ADH independent processes are very, very rare. One is primary polydipsia. That means that you are taking too much fluid. For example, for some reason you are drinking 20 liters of water per day. That is abnormal. So that will result in hyponatremia. That is due to primary polydipsia. That is going to be ADH independent, and that will result in a low urine osm. Second thing is maybe due to something called beer potomania. So basically, you need a little bit of you need a little bit of solute in your diet to excrete out water. So if you're not having enough protein in your diet, if you're not having enough solute in your diet, then you'll not have enough solute in your urine to excrete out water. So more water will be retained, and more water retained will lead to hyponatremia. So that is how beer hyponatremia leads to hyponatremia. Those are all very rare causes. Most of the causes will be ADH dependent only. That will have a urine also more than 300. So the next thing we'll have to ask is, it is ADH dependent. The next thing we have to ask is whether it is appropriate ADH or inappropriate ADH. So whether to decide whether it is appropriate or inappropriate, we have to look whether the RAS system is on or not. And to check whether the RAS system is on or not, that is why we look at the urine sodium. So if RAS system comes on, what will happen to the urine sodium? Urine sodium will be low. But the thing is that RAS system can be activated normally and abnormally. Normally, if the patient is hypovolemic, patient having severe vomiting, severe diarrhea, burns, sepsis, urine also. So in that case, patient will be hypovolemic. In that case, the RAS system will be activated and the urine sodium will be low. That is appropriate. So in that case, ADH will also be activated, and that will be appropriate. In another scenario, the patient will be having heart failure. Heart failure means patients have a decreased blood flow to the kidney. So the kidneys will think that it is actually a hypovolemic state. So in that case also, there will be appropriate ADH secretion, because the kidneys are actually thinking that it is hypovolemic condition, but it's actually due to decreased blood flow. But in that case also, RAS will be activated, and in that case also, again, urine sodium will be low. So urine sodium low means usually less than 20. 20 to 40 is a bit of a gray area. But suppose the urine sodium is high. If the urine sodium is high, that means that even though the ADH is activated, the RAS system is not active. If RAS is activated, sodium should be reabsorbed. So sodium is not reabsorbed, that means that the sodium is being excreted. That means that the RAS is not activated. So that means that it is inappropriate ADH secretion. So this can be due to SIADH, but SIADH is actually a diagnosis of exclusion. So it can be due to hypothyroidism, can be due to adrenal insufficiency, and these things that medicine people usually be required to rule out. But if the RAS system is not activated, but the ADH is activated, that is inappropriate. Whether it's SIADH or not, that depends on whether we have ruled out the other causes. Because SIADH is basically a diagnosis of exclusion. And very important to always look for the drugs. And as Karthikeyan said, most important drug is thiazides. Thiazides are notorious for causing SIADH and can happen very quickly. Maybe patient was started on thiazide 1 or 2 weeks back, then the patient is coming with seizures. That has happened. So it is possible, and that is something we always have to keep in mind. Another patient is coming in with severe symptomatic hyponatremia, always look at the patient's drug list. I hope that made sense. I don't have any slides and all, but I hope that makes sense.
Sir, it was a very good summary.
And actually, I would like to ask one doubt to our seniors. So one day we had a patient, sodium was 117, patient was altered. But patient's malaria test also became positive. Patient was positive for Plasmodium falciparum. So in that case, what would you do? Would you just treat for the malaria and see what happens? Or would you treat for both the malaria and as well as the hyponatremia and treat both at the same time? What did you do? I'm interested in what our seniors would say in that scenario, because this is something that I've seen in the counter area.
The patient is having features of I think you were meaning that you are suspecting cerebral malaria as a possibly altered sensory versus hyponatremia.
Sir. Cerebral malaria versus hyponatremia.
Yeah, so as long as I don't see any contraindication in this case to start ACT anyway for the patient, even if you're suspecting cerebral malaria. So I would go ahead with ACT as well as if the patient is acutely symptomatic. Yes, 3% in assess, like Karthikeyan had described, along with further evaluation for hyponatremia to find out if any other causes present in disease. So even cerebral malaria itself can cause SIADH also. So that is another point. I would start treatment concurrently for and evaluate hyponatremia along the way. So that would be my approach there. And like Karthikeyan had said, like after bolus of 3% NSE also, the sodium has risen by 4 to 6, and still there is no improvement in the patient's symptoms, then it is unlikely that the worsening of sensorium is due to the hyponatremia. So in either case, that won't change my treatment decision since I've already started ACT for the patient. Surya ma'am, any other comments?
No, I would do the same. I would start the patient on treatment in lines of cerebral malaria. Along with that, I would like to evaluate and treat the hyponatremia. 117 is like pretty low sodium, right? So I would like to treat that as well. Otherwise, in a case of SDH with hyponatremia, I would treat the hyponatremia. Just go ahead with SDH management.
Oh, okay, ma'am. That's exactly what we did in that particular stage. I just wanted to
So I would treat both. Evaluate for the cause of hyponatremia, start treatment in lines of malaria as well as hyponatremia.
I think if anybody else has any doubt, they can put it in the chat box if they don't want to speak. Otherwise, we can continue with the session.
Continue, sir. I think 1 hour we'll call it a day maybe, because maybe electrolytes will abhi to sir hyponatremia or hypokalemia is what we are discussing. So we'll take it as a bunch of sessions. We'll think of including other electrolytes as well along the way. Maybe next time we'll do something of hypokalemia and say hypocalcemia or something together.
No, I think you can take hypokalemia and hyperkalemia together. Next, it will be.
I agree with that, because hyponatremia is a little bit complicated topic. It takes some time. I think potassium disorders you can club together. I think that's okay.
I think we can have a class on hypo and hyperkalemia and calcemia separately, because I am really interested in attending dyslipidemia classes.
Yeah, we'll do it like that. If anyone of you has any doubts, now would be the time to ask. I'll just stop the recording for the time.